Hello, thank you for asking me to present at the CCLG Childhood Cancer Conference 2021. I'm Martin Elliott, I'm a Paediatric Oncologist in Leeds, and I'm the UK Chief Investigator for the new high-risk neuroblastoma SIOPEN study. I'm going to give you a brief overview of the aims and objectives of the study, update where the study's up to across Europe and the UK. So, high-risk neuroblastoma 2 study is a SIOPEN study. So SIOPEN is a consortium of 29 countries who perform research and do clinical trials in patients with neuroblastoma. The predecessor to this study was the high-risk neuroblastoma 1 study, which ran from 2002 to 2018 and had multiple amendments and closure of randomizations and introduction of new randomizations during its lifespan. The sponsor for the new study is Gustave Roussy in Paris, and each country has its own co-sponsor, which for the UK is the CRUK CRCTU in University of Birmingham. And we're very grateful to the funders of the UK part of the study, and the funding is a collaboration between Solving Kids Cancer and Neuroblastoma UK. So a little bit about neuroblastoma first. So neuroblastoma is the commonest childhood solid tumour, apart from brain tumours. There are approximately 100 cases a year of patients with neuroblastoma, and 50 of these patients will have high-risk neuroblastoma. And I'll clarify later what we mean by high-risk neuroblastoma. The neuroblastoma can only arise in 2 places in the body. It can either arise in the adrenal gland, which is a gland that sits on top of the kidney, as pictured there, or it arises in something known as the sympathetic chain, which is chains of neural tissue or nerve tissue that run along the bones that make up your back, and they're known as the sympathetic chains. And they run from your neck right down to the bottom, and neuroblastomas can arise in either the sympathetic chain or in the adrenal glands. So investigations that patients have would be imaging of their primary tumour, which will normally be MRI scan or CT scan. And then they have a number of investigations to establish whether they've got localized disease or disease that has spread to other parts of the body. Neuroblastoma usually spreads to lymph nodes, bone and bone marrow, and less frequently to liver, lungs, skin, and brain. And the usual scans that are done to stage patients would be a MIBG scan, which is a scan that's specific to neuroblastoma and will show neuroblastoma anywhere in the body. Or we use a PET scan, and this is used in the small number of patients whose neuroblastoma doesn't take up MIBG. And we also do routine bone marrow tests to complete the staging. So neuroblastoma, like I said, is the commonest tumour, solid tumour of children, but it accounts for 15% of the deaths. So it's got a disproportionate number of deaths compared to the actual incidence. And it is therefore one of the current big challenges in paediatric oncology to improve outcomes. Neuroblastoma isn't one disease. It is split into low, intermediate and high risk. And from the graph there, you can see that the survival for the different risk groupings alters significantly, but from being very good in low and intermediate risk to about 40% in patients with high risk disease. Don't worry about the graph there, but basically every patient with neuroblastoma is categorized from a number of factors, including age, stage of disease, the biology of the disease, certain genetic features of the disease, and everybody comes out with a risk group on the right-hand column. And patients for the SIOPEN trial will all be patients who have high-risk disease. And a simpler way of looking at it is any patient over the age of 12 months who's got metastatic disease would be eligible for the high-risk trial, or any patient of any age who has got a particular genetic change in the neuroblastoma cells called MYC amplification would be eligible for the trial. A quick overview of the standard treatment of patients with neuroblastoma. Patients get, first of all, induction chemotherapy treatment. They then get something called a stem cell harvest, which is the PBSCH. So that is taking stem cells to be frozen down and used later on in treatment. Patients then usually have an operation to remove the primary tumour or attempt to remove the majority of the primary tumour. Patients then have something called high-dose chemotherapy, which is where you give a one-off, very high dose of chemotherapy drugs. And you then use the stem cells that you'd collected and give those back to encourage the bone marrow to recover quicker than it would do if you didn't give any stem cell rescue. Patients would then have radiotherapy treatment to the site of the primary tumour, and then have a combination of immunotherapy and differentiation therapy. So by immunotherapy, we mean anti-GD2 or dinutuximab beta in the UK, and the differentiation therapy is cis-retinoic acid or high-dose vitamin A treatment. And what you can see is clearly the whole treatment period is approximately 1 year. If you have any delays or any significant complications, then obviously this can easily become longer. So this is an overview schema for the high-risk neuroblastoma trial. There are 3 randomizations, which I'll go into more detail in a minute, but one is the induction, so we're looking at using 2 different induction chemotherapy regimens. Then we're looking at exploring whether 1 or 2 high-dose chemotherapy procedures is more effective. And then some patients will be eligible for a radiotherapy randomization that I'll talk about soon. So the objectives of the trial are, there's 3 main objectives. There's lots of secondary objectives, but the main objectives are to look at 3-year event-free survival in patients who have 2 different types of induction chemotherapy, to then look at event-free survival in patients who have a single high-dose chemotherapy schedule compared to those that have a double or tandem schedule. And finally, it's to look at 3-year event-free survival in patients who have evidence of residual tumour after their operation and are then randomised to either have standard dose radiotherapy or standard dose plus a boost of radiotherapy. So looking at the induction chemotherapy randomisation, the current induction chemotherapy we use in UK and across Europe is known as rapid Kojak, and that's very well established and is the standard in Europe. In the previous trial, this was compared with an alternative induction regimen called modified N7, and that didn't show any benefit. In fact, the event-free survival was the same for both treatments, but there was more toxicity with the alternative, and therefore rapid Kojak has remained the standard treatment in Europe. Germany used to run their own neuroblastoma trials, but recently they have joined the SIOPEN consortium, and this has therefore given the opportunity to compare the European standard rapid Kojak with the German regimen, which is known as GPOH. These are very different regimens. The rapid Kojak one is given every 10 days, and it's a relatively compressed treatment, relatively intensive, and takes 80 days to administer. The GPOH regimen takes 126 days, and it's standard chemotherapy given at 3 weekly intervals. And for patients who are randomised to the GPOH arm, they will also require additional scans. So there is extra time of 46 days and also the burden of extra scans for patients randomised to the GPOH arm. Then we are exploring the role of 1 high-dose chemotherapy procedure compared to 2 high-dose chemotherapy procedures. And why are we doing this? So recently, COG, which is the Children's Oncology Group in America, did a trial comparing 1 procedure with 2 procedures. And the graph on the right at the bottom shows that for the 2 procedures, or known as tandem, there was a much better event-free survival compared to those who only had a single transplant. The caveat to this is this benefit was only seen at a sort of statistically significant level in those who went on to have immunotherapy, but that would be the approach in Europe. However, the COG, the drugs that is used in the COG high-dose chemotherapy, are not busulfan and melphalan. They use CHEM, which is carboplatin etoposide melphalan, and therefore we can't assume that just introducing a tandem transplant into European treatment would have the same benefit, and therefore this has to be done in a proper randomized clinical trial. So patients will be randomized to have either standard treatment, which would be Bumel, or high-dose Thiatipa, followed by Bumel. So for patients assigned to the tandem, they would get high-dose Thiatipa, they would get stem cells back, they would then have an 8-week gap before they then have the standard treatment of Bumel, again with more stem cells. So clearly this is another additional 8 weeks of treatment added to an already lengthy treatment protocol. There will be additional burden of time in hospital, possibly additional toxicity from the high-dose Thiatipa, and patients also need an additional MRBG scan. In COG, they did show that the tandem was tolerable and there was no significant increase in toxicity. Then the final randomization is the radiotherapy randomization. So this is only for patients who've got residual tumour, and that would be either decided by the surgeon who did the surgery, who thought that there was more than 5 mils of residual tumour left, or the scans done after surgery show evidence of residual tumour. And what would happen for patients in that situation is they would get randomised to receive either the standard radiotherapy dose, which is measured in grey, that's 21.6 gray, or they would get the standard 21.6 gray plus an additional boost of 14.4 gray to the residual tumour. All patients on the SIOPEN high-risk 2 trial will have all of their radiotherapy planning scans reviewed centrally as a quality control measure. Trial progress. So the trial opened in France in 2020, as they're the lead country and they're the sponsor for the trial. The UK opened in August 2021 and has recruited its first patient, and hopefully other sites will open very soon and start recruiting patients. The target for the UK is 204 patients. Also, there is an exciting animation project being done by Helen Pearson, clinical nurse specialist in the Marsden, and this is a series of videos that will be able to be accessed and explain each of the aspects of the trial to patients and families, and sort of to facilitate the patient information sheets that are part of the trial, and hopefully these will be well received, and particularly for older patients and teenagers, be much more encouraging and stimulating than a rather bland patient information sheet. There is also going to be an amendment to the trial. So Solving Kids Cancer have funded a lalatinib amendment, so that is in collaboration with COG. Patients who have got something known as an ALK mutation in their tumour, which is about 10% of patients with neuroblastoma, will access a targeted treatment called lalatinib, and that will be given for the majority of their treatment. And that we would hope to have that amendment open in 2022. On a positive note, if you look at the outcomes for children with neuroblastoma and grouped by different trial cohorts, so that's the top graph, and the years are chosen that map to clinical trials that have been open, you can see that there has clearly been a sequential increase in survival, and that is continuing. And the bottom graph shows the latest figures for 2011 to 2015, and there is a continued gradual increase. Obviously, the bottom graph is for all patients with neuroblastoma. It won't just be high-risk neuroblastoma patients, but the majority of the improvement will be in those with high-risk neuroblastoma, because unfortunately those are the patients who account for the majority of the deaths. deaths. So thank you very much for listening. I'll be pleased to take any questions during the question and answer time. Thank you very much.